everybody for joining us. Again, a lot of y'all's faces are very familiar. We've done some of our virtual info sessions together and gone over what the curriculum at Northwestern is like, and we've talked about the application process too. And so now we have the opportunity to connect with you on another level. We get to share some of our brilliant faculty members from the ortho/musculoskeletal team here today with us. And so before I open up the floor for them to do their introductions, again, I'll go ahead and reintroduce myself for any of you who I haven't met before. My name's Daniel. I'm Assistant Director of Admissions at Northwestern's Department of Physical Therapy and Human Movement Sciences. And my main role is to recruit students to our department and to help you through the application process. So I wanna make sure that the application process is as smooth and as stress-free as possible. And so I am now gonna have Dr. Amy Seitz and Dr. Allison Chang introduce themselves. I guess I'll go ahead and have Allison go first. And I guess, Allison, if you could tell us what you teach, how long you've been at Northwestern, your clinical practice, and your research interests, that would be super awesome.
Okay, great. Hi, everyone. Thanks for taking time to join this Zoom meeting to chat with us. I'm Allison Chang. I've been at NU for almost 15 years. I went to graduate school at Northwestern too, so I've been here a long time. I'm an associate professor now, and my clinical practice is mainly in orthopedic and sports physical therapy, primarily focused on lower extremity, so mostly knee, ankle, and foot. And I teach in gross anatomy, kinesiology, and musculoskeletal series. My research is mainly focused on pathomechanics and management of degenerative or overuse injuries of the lower extremity. Again, it's mostly focused on the knee, so the entire spectrum of, my research is mostly on knee osteoarthritis, but the spectrum of after you have had a meniscal injury or ACL injury, you're kind of on the trajectory of having knee osteoarthritis. So it's sort of like pre-OA, confirmed diagnosis OA to the very end stage of OA and eventually getting total knee replacement. And I use gait and movement biomechanics to examine patient and also use epidemiological methods to follow large cohorts. What else? Oh, the other thing is because of my clinical interest, I do video-based and biomechanical analysis of running. So that's more like a clinical interest of mine. What else should I say, Daniel?
Taking myself off of mute. That's really good. And whatever else, anything fun, any interesting facts?
Well, okay, I can do one interesting fact. It's a really odd fact. So I bought a car before I had a driver's license. So there's a story behind this because I grew up in Taiwan. So I came here for graduate school. And at that time, I did not have a license here. So, but a friend of mine was leaving the country and he wanted to sell me his car. So I was like, wait, that's great. I can buy a cheap car and I'll figure out how to get a license. So I ended up buying a car before I had a license. So I learned how to drive on my own car there.
That's super fun, Allison. I actually bought a stick shift car before I learned how to drive it. I just loved the car so much. I was like, I'm gonna learn. I don't care. So I stopped on the road. Tons of people honked at me because I kept stopping, but it didn't matter. So I can relate a little bit. Yeah.
It's kind of like, buying a size 2 pants so you can fit in and lose weight.
Exactly. Right? You will make yourself fit. Exactly. Well, thank you, Allison, for that introduction. So we'll go ahead and have Dr. Amy Seitz introduce herself, and then she'll go ahead and transition into talking about how the musculoskeletal curriculum fits in to the entire DPT curriculum as a whole. So we'll go ahead and open up the floor for you, Amy. Thank you.
Great, thanks so much. I appreciate the opportunity to chat with you guys. I'd like to keep this as informal as possible. So if you have any questions, feel free to just put your hand up. It's easy to see everyone in this video, at least from that perspective, but we'll provide an opportunity for questions later. So I think I've been here at Northwestern for 6 years now. I moved from Boston. I was in a faculty position at a large institution in Boston. And my clinical practice expertise and area is in musculoskeletal upper extremity injuries specific to the shoulder. I had an opportunity to specialize when I was a clinician. I worked at Mass General for about 10 years in Boston. And I worked hand in hand actually with the surgeons. So I would see patients with the surgeons in their office, which gave me a whole nother perspective on care of patients with shoulder pain. So that was a fantastic experience. I think, certainly it kept me stimulated for quite a while. And then I went back to get my PhD so that I could actually contribute to the literature and what we do from a efficacy perspective in PT for shoulder injuries. Because when I was trying to help patients, I would try to look up, all right, here's the best evidence for this. You should try this as an exercise program. And we were really, there's a paucity of research. So I decided, you know what, I'm going to be one of the ones that try to contribute to this. So that's kind of been my research focus. So I've branched out a bit. Initially, I started in rotator cuff disease, and now I'm looking at things like total shoulder replacements. So if you have osteoarthritis of the shoulder, as well as instability. So I have a couple PhD students that work with me. They're really dual degree students, so either DPT PhD students or MD PhD students, which is it's really fun to work with them. So anything else I'd like to add? I'll keep it G-rated, so that's good. I think the one thing since I've been home, we've been trying to commit to getting a puppy for, I don't even know how long, maybe 5 years since we've been here in Chicago. And of course now we want to pull the trigger, and it's apparently it's called the puppy pandemic. So good news is we're expecting.
Yes. When?
But, it should be middle of July.
Wow, real soon.
Yeah,
good.
It's good, yeah.
Have you met your puppy? Or the puppy is still in utero?
No, the puppy's born. So we're watching the growth of the puppy.
Okay, got it.
In video, yeah. So I think from a musculoskeletal curriculum perspective, I can say that we have 3 musculoskeletal courses. They run in the second year. So after your first clinical, between the first year more foundational courses and the second year, we start up the musculoskeletal 1 course. So that course really we provide some foundational knowledge in that course. And then we really start with like knee and foot and ankle injuries, and Allison contributes quite a bit to that course. And then the second course that we have is really focused on lumbar spine, lumbar spine, hip SI joints, and then we hit some thoracic spine and TMJ. And at the end, in the summer, you go on a clinical before you come back. So it allows you to integrate some of the information from MSK1 and MSK2. And then you hit MSK3 for the second half of the summer. And we focus really on cervical spine, shoulder, and upper extremity. So we have a really great team. I think the team has evolved over the last 5 years, and I'm really excited. We have, Craig Hensley has been a great addition to our faculty. He's a fellowship trained, residency trained at USC, fellowship trained at UIC, and he is an amazing clinician. So he's taught in residency programs, he's taught in fellowship programs, and he certainly is an asset to our MSK team. The other person that's not unable to make it tonight is Courtney. She has a great experience in teaching in MSK as well as starting and running fellowships. So she's started a fellowship, and we are starting a fellowship here now in orthopedic manual physical therapy. So I think that's kind of the overview of the MSK curriculum. I'm happy to provide more answers to questions that you may have, but I don't want to keep rambling.
Thank you so much, Amy. That was awesome overview. And so what we'll go ahead and do next, the floor is open for you all to ask some questions. And I see when you all signed up, I get to see where you're all from. And we've got folks in here from Arizona, from California, you know, way over, you know, to Michigan and Illinois, and even I think Pennsylvania, and where else? I think New York we've got in here too. So it's pretty cool. So we'd love to answer any questions that you may have about the musculoskeletal curriculum, you know, labs, faculty, student relationships, anything like that. We have Amy and Allison here to answer. And so if you're not familiar, we're going to use the hand raise feature. If you see where it says manage participants, you can click that, and then where it says more, no, is it under more? Somebody help me out here.
Let's see. I just raised my hand.
Oh yeah, Allison, you just raised your hand. How did you do that?
So under participant, you click on participant, then you see your name, and you put the cursor there, you see mute or more, click on more. Then on the bottom ribbon, there's a raise hand, yes, no, go slower, go faster, coffee break, clapping your hand, any of those. Yeah.
Okay.
You guys
cool.
see it?
And if you're struggling with that, go ahead and you could just raise your hand. We're trying to be techie here and use all the features, but if you're struggling, just speak up. We're all friends here. Anybody want to start us off? Okay, three participants raise their hand. So we will go ahead and go with Clarence first.
Hi everyone, I'm Clarence, and something I was curious about was during the previous information session, one of the current students mentioned that a lot of what we learned for orthopedics PT would be through the MSK courses, and I was just wondering if there were any additional courses in the curriculum where we continue to add to the toolbox of orthopedics PT, and if not, what other extracurricular activities or opportunities there are for us to continue to add those skill sets.
Allison, you want to go first?
Okay, I can go first. So, like Amy said, we have MSK 1, 2, 3. So that's during the second year. There are 3 trimesters, but really our curriculum is kind of build up to that moment that you can really learn how to manage MSK patients. So at the very beginning, gross anatomy and kinesiology are synced in a way that whenever you're dissecting a specific body part, to say shoulder, in gross anatomy, in kinesiology, we're learning about shoulder mechanics. So then we have E&E, examination, evaluation, and foundation. Those are actually foundational courses to build up to MSK. Then if you're thinking about more advanced skills or advanced learning about MSK, we have a course called Complex Patient. So in that course, student work, usually 6 or 7 students working with one faculty with expertise. And often we have cases that's complex in nature, MSK related. Also in that complex patient course, we have specialty topics. For example, we have a special topics, sports physical therapy, or specialty topics on pelvic health. So, so it's kind of peppered around different parts of the curriculum. Amy, you want to add any more?
No, I think that's great. We started we call them electives within that complex patients course about 3 years ago, I think. And so we've had various, invited speakers that might give a day symposium on various topics. More recently, we've been fortunate to pair with Northwestern Athletics. And so we have, a great athletics facility up in Evanston. We've had the opportunity to go up there, work in the weight room with their strength and conditioning specialists. We get to see the dietitians. We get to hear a lot more about how they, care for, I guess, not a professional level athlete, but certainly a higher level athlete. So that's been an excellent opportunity, and they're offering that again this year. And I foresee that kind of continuing as we move forward.
Thank you.
And yeah, that's great. That's the other thing I want to add just came to me is that our department has grant rounds, monthly grant rounds, and often the speakers are nationally or internationally known, and all these grant rounds cover a wide variety of topics. MSK is one of them. So I would say, Amy, you would just say like we usually have 1 or 2 speakers a month, sometimes even more. So those are great learning opportunities to hear like really, really well-known speakers. Also, we're connected with Shirley Ryan Ability Lab. They have their seminar series too. So that's another opportunity if you want to learn more. Chicago is just a very rich environment. If you want to learn more, there are so many like talks you can attend. And as a student, often the fee is minimum. Sometimes it's free, sometimes it's like $50 for a 1-day seminar. So there are a lot of opportunities for those.
Thank you.
All right, so we got next. Let's see, we'll go ahead. Is it Chisholm? Is that the best way to pronounce it?
It's Chisholm.
Okay. Chisholm, you're next. Thank you.
Thank you. Hi, everyone. My name is Chisholm. I'm from Westtown, right here in Chicago. So my question is how, so I know a lot of schools are either research-based DPT programs or clinical-based DPT programs. What would you rank Northwestern in relation to that, or is it just a combination of both?
I guess we're teaching a clinical skill, so it'd be really hard not to have a clinical-based program. I would say we certainly have research, and we're strong in research. All the students have an opportunity, if they wish, to participate in a research project with faculty in their last year of, actually throughout the curriculum. They select these, and Allison can speak more about these synthesis projects. But they also run the gamut, those projects, from anything helping from a teaching perspective in anatomy to service learning opportunities in underserved communities where you go out and potentially work with faculty evaluating and treating patients in underserved communities. So I think, we certainly are strong in research. We're an R01 institution, but our clinical faculty are, because we're so large, I feel like we have expertise that provides a greater depth in the clinical courses that you may not get in a program that's taught all MSK by 2 or 3 faculty. So we have 5 total faculty that contribute to the MSK course series as core faculty, and then another 8 to 10 adjunct faculty that help us in every lab. We overstaff our labs. We're at a higher ratio than what is required. We also have residents that assist in the lab, and we don't count them in our kind of ratio. So I feel like we have strengths, certainly both in clinical and research. So I'm probably a little biased.
Sounds good. Thank you.
Yeah, I just want to dovetail what Amy has said. I think because of our large faculty body, so we have strength and expertise in both research and clinical work. And they're both super strong. And for me, I still feel like I'm learning every day from my colleagues. And if I need answer for something, I can always find someone within the department who has that expertise, just because we're so big. And the other thing Amy has alluded to is that we do team teaching. We also try to match people's research expertise with their teaching content. So for example, Amy is a really well-known expert in shoulder. So she teaches shoulder in kinesiology, she teaches shoulder in MSK. And my area is more foot and ankle and knee. So I teach knee and foot and ankle in kinesiology and MSK. But I don't know a whole lot about shoulder, even though I can treat a shoulder patient, but I definitely won't be as good as Amy. So I don't teach the shoulder part. My job is just to help out with the lab. So I feel like we really match our expertise with our teaching really well. So that makes the clinical program really strong. Also, we're teaching really the most current evidence and research content in that specific region of the body too. So
I think one thing that represents that well is that if you look at our combined sections meeting, which is our large meeting for all physical therapists, I think it's up to 18,000 attendees every year. Our faculty are represented in a lot of the educational sessions that are presented to other physical therapists and other academic programs that are attending. So I feel like, we're at that level that we are leaders nationally in orthopedics. We have, several authors of clinical practice guidelines, which are guidelines that outline the best evidence for clinical care related to shoulder, knee, hip, what have you. And we have several faculty on staff who contribute to those. So I feel like, we have the expertise both in a clinical realm as well as in a research realm.
Thank you.
Chisholm, you probably didn't expect such a long answer. Sorry,
Oh, that was
went on and
greatly
on.
appreciated. Thank you.
You can tell we've been cooped up at home, just like a few people. Allison at least has a family. I have one significant other, my husband, and we're at opposite ends of the apartment. So I feel like I need a little socialization. So sorry for the long-winded answer.
Also see fresh faces. It's really good.
Awesome. So thank you, Chisholm, for that question. So next we've got Mary Kate, and then we'll get to you, Helen. And before you start, Mary Kate, if any of you are shy and you don't want to ask your question out loud, feel free to send it in the chat. You can send it directly to me if you'd like, and I'll just ask it out loud anonymously. Feel free to do that too. So Mary Kate, take it away.
Hi there, I'm Mary Kate. I'm doing a career change, so after some orthopedic experiences. So I'm excited to be here and hear what you guys have to say about the program. It's definitely an area of interest for me. I'm sure a lot of students come into orthopedics having a general idea. That's typically what I think of when I think of physical therapy at first anyways. So I just have a couple questions. One, I'm curious to know what students go into their orthopedic classes knowing or having an idea about it, and then what do they come out of it that might be surprising for them, specifically going to Northwestern and things that they might be learning that they weren't sure of before, for good or for worse, I guess, if it helps them decide. And then just another question in regards to the electives and specialization within orthopedics. If graduates come out less specializing in a certain area, or if it's kind of up to them to decide once they are looking for a job afterwards.
Allison, I'm looking at you, just praying you're gonna start because there's
This
a
one
lot
to
of
start.
questions.
All right. So yeah, thank you for all these questions. Let me think about, I'll do the first one, you do the second.
Okay.
So the first one, you're saying like people coming with a specific mindset about what ortho PT is like, and as they go through the program, what are the surprising things they learn about it? Okay, so the first thing that came to my mind was actually interviewing. So a lot of time people who are attracted to ortho PT, they want to learn lots of manual skills, hands-on skills, how to examine a patient. So they feel like they will come in, learn a boatload of skills and leave the program and be able to treat patient. But our program is very, very focused on teaching you how to think. So, and to think through a case, the most important part at the beginning is interviewing. How do you gather information about your patient? We spend a lot of time in E&E, examination evaluation, to teach students how to ask the right question to get the information they need. It requires a lot of skill, probably more than you think it would. And the other thing is, after you interview someone, get the information, you should be able to already, I would say, experienced clinician like Amy and I probably, but we're like 80-90% kind of know what's going on with the patient. And we already have like 3 or 5 hypotheses what could be wrong with the patient. We might even have a pathoanatomic diagnosis at that point. We just have to confirm with our manual testing the patient. So a lot of students, after they go through the program, they realize, wow, interviewing is actually really powerful. How you gather information, right? And the second one would just be thinking, like the clinical reasoning, the thinking skill. We really emphasize that because we want you to be able to go out there, no matter what kind of patient you have. You've never learned a specific diagnosis in school, that's okay. You could think your way out of it. So we have a lot of frameworks we teach you in terms of how to think through a case, how to do your differential diagnosis, how to formulate hypotheses, how to structure your exam. So those are things I think maybe students were surprised that they have, that's actually the most critical piece of being a good therapist.
And to dovetail off what Allison was saying, when we invite recent graduates back, at graduation, we have a session where we ask, what did you like about the program? What do you think we could do better? The things that they say they're most surprised by is how important the psychosocial aspects of what they learned. I think we have 4 or 5 semesters of psychosocial coursework that helps integrate the biopsychosocial model. And I think from a pain perspective, it's very important to be able to understand that in care of patients. And so there's more research that's come out in the last 5 years with regards to this. And certainly, I think we do a nice job integrating that component that was underappreciated as a student until you start working more with patients. So, all right, so now I've really lost your first question. So if you don't mind repeating, that would be great.
Sure, that was great. Thank you so much for that. So my second question is mostly in regards to go back to the electives. Specifically, do students are they able to specialize within orthopedics at Northwestern, or is it you can take the elective courses and make that decision once you've graduated and passed the boards and all of that?
Yeah, so I think, in general, the entry-level programs are designed to create someone who can treat anyone, right? So I think that that's the foundation to all entry-level programs. Certainly, we offer opportunities to allow you to gain more knowledge in an area that you may be interested in, whether that's acute care, whether that's, sports, whether that is in women's health. So I think these are all things that are offered as additional opportunities. But when you graduate, you are certainly not going to be specialized. I mean, entry level is entry level. They have the orthopedic clinical specialty exam, and there's certain requirements for the number of hours that you need to practice in order to sit for that, as well as the knowledge base that you need and experience really to specialize. So I think most programs, I don't think they can say they graduate anyone that specializes, but certainly they have opportunities where you can take additional electives and feel more confident in one area based off your interests.
Okay.
Yeah.
That makes
I have just another thing to add. So yeah, so I totally agree with Amy. We're producing, we hope our student coming out to be a well-rounded clinician, right? So if you want to specialize, it'll be down the road of your professional trajectory. However, while you're in school, if you're interested in a specific topic or area, you have the opportunity for electives. You can also just find mentors within the program or outside of the program. For example, I'm working with working with a second-year student because in kinesiology, I taught about running biomechanics, and she got really interested. So she's been meeting with me on a regular basis to talk about topics that's beyond what we teach in class. But she has to do a lot of homework too. She comes in with things she's read, she's learned, and she just asks questions. And she also found an alumnus in Seattle. She also runs a running clinic. So 3 of us actually sometimes meet remotely, you know, through so we talk about things. So for her, that's her learning outside of what's required of her. And that with the hope that maybe eventually she wants to specialize in that. I also have a student who was a collegiate golfer. So she's really into golfing mechanics. So she found, again, courses around Chicago. She found alumnus who treats a lot of golfers. So she sort of like create a learning mentoring team for herself. But it takes a lot of initiative and also desire to learn because our curriculum is pretty intense. So she still finds time to do that. But then so basically, I would say the world is your oyster. If you have a specific area you really want to learn more, there are resources out there. You just have to find them. Yeah.
Yeah. No, that's great. Thank you so much.
And also wanted to pick your brain a little bit, Allison and Amy, because I know with our curriculum, we have the synthesis project as well, where students have a choice. They can prioritize which projects. And so, Kate, if you're maybe into orthopedic, you know, ortho might be a path you want to take. And again, you can't necessarily specialize, but you know, there are professors who are working on projects that might lean towards that way or go down that path that you can focus on as well, right, Allison?
Yeah,
Amy?
that's a great point. Yeah, I forgot about that. I'm the co-director of synthesis, but I forgot to mention this. Yes, like Amy has talked about. So we have 20 some projects for the class, for each class. So so students get to listen to the project pitch and try to match with their mentors or professors. So usually you're matched with your top first or second choices. So that's another opportunity to be involved in something you really are curious about. Like someone wants to work with pediatric patients, maybe they'll pick a pediatric project. Someone wants to work with shoulder, work with Amy. Somebody wants to work with knee, work with me. So yeah, there are many opportunities like that.
Thank you. Thanks for adding. And thanks for that question, Mary Kate. So we have Helen next. So Helen, you can go ahead and ask your question, then we've got John after that.
Hi, I'm Helen, and I'm an undergraduate at University of Michigan. And I'm wondering how you guys ended up in a career in teaching. Like, what is your thought process when making the decision?
Amy, you want to go first?
It's like the faux pas that is haunting me now. Make sure I unmute every time I talk. So I think PTs are teachers in general, because you're teaching your patients every single day. And then, so that's how things started for me. And then when I was practicing, I started mentoring students, DPT students who are trying to get training, right, in the clinicals. And so I really enjoyed teaching the students. And so once I had several years under my belt teaching the students, I had an opportunity to do some adjunct teaching. I was asked to do this if I wanted to do it. And, you know, I come into the labs similar to our courses where we have clinicians in different environments come in and help in laboratory skills. And so, I mean, that I was hooked, right? I had the opportunity to not only practice, but I could teach and help form, you know, knowledge, not only for my patients, but also for future physical therapists. So I think, you know, at some point in time after practicing, you know, 17 years or so, I decided maybe I could do this full time. And that's when I made the switch.
Yeah, my story is quite similar. When I was in grad school, I had the opportunity to do adjunct teaching. And once I started, I was like, wait, I love this. I get paid for like nerding out or geeking out about things I'm so passionate about. It's like, that's a great profession, right? So, and like Amy said, we teach patients every day. And it's such a stimulating environment when you're teaching, because we have high caliber students. They always challenge you, they stretch you, ask really good questions. Then just makes like your day-to-day work really exciting. And the other thing is, I always tell like third year students when they're graduating, because I started with them in kinesiology fall when they start, right? That's the first trimester. And I see the growth within 2 to 3 years. It's amazing. It's a miracle in a way. It's like they have grown so much from the beginning, being shy and really do not have a lot of foundation about physical therapy, to the point when they're the third year, I would trust them with my family. I would trust them to treat my family. And that's a great feeling. Like it's a pretty awesome gratification as a teacher. So we're really lucky.
Thank you. Those are some really good vibes.
Awesome. Thank you for the question, Helen. And so we've got John next. You can go ahead with your question.
Hi guys, I'm John. I'm from the northwest suburbs of Chicago. This is also a career change for me. I was curious to know how you guys decided to get into ortho as opposed to other specialties such as pediatrics or neurology. Was there a certain, situation that occurred or something that happened to you guys early in life? I just wanted to see what your guys' take was on that.
Your turn to go first.
Oh, wait, I missed. I was responding to a chat.
Oh, your turn to go first.
All right, good. Should we do rock, paper, scissors?
Yeah, that's right.
So the question is, how did I get into ortho? Well, I'm a linear thinker, and I like mechanics and physics a lot. So ortho is sort of like a natural choice for me, because PTs are looking at movement, right? So a lot of time you look at movement, you think about movement mechanics. So ortho seems to fit into that mode of thinking. And also, I like treating ortho patients or evaluating ortho patients like putting a puzzle together. So it's like during your interview, you gather, let's say, 10 pieces of the puzzle. Then you almost have a picture, you can see it, but you're not quite sure. Then you do a couple more exams, you have more pieces coming together. Then at the end, you complete a puzzle after you complete your initial evaluation. And that, I love that feeling of like putting things together, working through a puzzle and try to figure out how to tackle a problem. Of course, then when you start the treatment, you also have to figure out how you should prioritize. And for ortho, the good thing is you try it, you know the result pretty quickly if it works or not. So I like that pace to compare to other specialties. That's my short answer.
That's a great question. That's usually a question that, you know, we would ask applicants, right? Why do you want to go into ortho? Why do you want to do this? So I could say a couple of things. Number one, my original exposure to PT was in an orthopedic setting. It was in a sports medicine setting, and I hurt my wrist playing softball. And from a standpoint of the PT, she was very impressive in the fact that she was able to detect or suspect that I had a fracture when I had an x-ray that was negative, but in fact, with follow-up testing, I did have a fracture. So that was just very, very like empowering. Like, wow, this person who is helping me get better, not only like can help me get better, but can also help identify things that are maybe outside of her scope, but she's really that skilled. So I think that was one of my first experiences. So going into PT school, that's really what I wanted to do. I think the other thing is that I think you find that you are in a very formative time in your life when you go on your clinicals. So if you have really good clinical placements with the CI, or for me, it was really my clinical instructors in PT school, I could relate to them easier. I felt like I had more in common. And I hate to say it, but that really was one of the main reasons why I'm like, wow, I love this. So great, because this professor's amazing. I want to be just like them, right? So I think one thing that is surprising to me is that I think we have a very strong pediatric group of faculty, you know, from a standpoint of the number of faculty within a program and being really good. They are involved in this Go Baby Go, which I would encourage you to look up on the internet, because it is just amazing. So they make cars, collaborating with engineers who are also students, potentially DPT, PhD students, or just engineering students within Northwestern. And they specially design cars for children with disabilities so that they could be mobile as children. And the process of seeing that is phenomenal. So there's a lot of people who come to PT school thinking I want to do orthopedics. That's the only thing I've been exposed to. But then they see a whole nother realm of expertise. And, you know, a lot of people end up choosing things like pediatrics, acute care. We have a really great acute care group. And, you know, if they get a clinical and they're really excited about it. So I feel like, you know, those decisions are really based off what turns you on once you come into an environment where you are exposed to other practice areas. Certainly, you know, MSK for me and orthopedics for me, I didn't deviate, but I do think, I do see that happen quite a bit in PT program.
Yeah, I think Amy made a great point about like keep an open mind about what you want to specialize, because I always tell my advisees that I've seen many people coming wanting to be sports ortho, and they end up going to acute, day rehab, pediatrics, vestibular, women's health, all sorts of specialties, just because they learned about it and they have great clinical experience and they decide to pursue that line of work. So I know you guys are interested in MSK, but definitely keep an open mind. You might surprise yourself at the end of the curriculum. It's like, maybe I like the other one even more.
Thank you, guys.
Awesome. Thanks, John, for that question. So next we have Cheryl's question, and then we'll get you, Valentina, as well.
Hi, everyone. My name is Cheryl Setlock, and I just graduated this past semester from the School of Kinesiology at the University of Michigan. So I have two quick questions. The first is I've heard a lot about the partnership between Shirley Ryan Ability Lab and Northwestern. So I was wondering if you could touch upon that a little bit more. And my second question is, you briefly touched on how DPT students can volunteer to assist Northwestern PTs serve underprivileged communities in the Chicago area. So I was wondering what other volunteering opportunities are available for Northwestern students.
Those are great questions. So who's up first?
I went first, your turn.
All right, I'm probably not the best one to speak about volunteer opportunities, but I can say that we have faculty who have expertise and a high interest in community health. And so they offer synthesis projects where they go out and work with a group in underserved areas trying to overcome challenges with like limitations in physical activity and obesity. So they create these walking groups and they follow them and they chat with them on, social media, and they really try to engage them. They've integrated research projects into those, but they've had a long time building trust with that community in various ways to volunteer. So that's one volunteer opportunity I can think of. And what was your first question?
I was asking about the partnership between the Shirley Ryan Village Lab and Northwestern.
Yep. I mean, that partnership started, I think it was 4 or 5 years ago now. Stemming from that partnership, we have an opportunity as faculty to treat over at Shirley Ryan Ability Lab. So we have a reciprocal agreement where we also engage their clinicians as contract educators in our clinical labs. So we have several clinicians from Shirley Ryan that have participated and continue to participate in the MSK course series. There's been joint residencies that have been established through that collaboration. The first one was an orthopedic residency. So we have an orthopedic residency where the students, or the PTs, I should say, that are in that residency come over and help in the MSK course series and in other classes so that they get some teaching experience. And then they also treat over at Shirley Ryan. We have didactic mentorship that's shared between Shirley Ryan as well as Northwestern with the expertise that we have in faculty. So I think, they have both musculoskeletal kind of outpatient clinic as well as, rehabilitation, specializing in anything from spinal cord injury to stroke rehab. I think they have some pediatrics. It's outside of my realm of expertise, but maybe Allison can chime in a little bit there.
Yeah, so in terms of collaboration, Amy has mentioned all those, and there's also, from a synthesis project perspective, research project, many Shirley Ryan clinicians and researchers do offer synthesis project for students. So you might end up working with a researcher at Shirley Ryan Ability Lab rather than one of our core faculty. So that's another interaction. The community engagement, we also have a project called PACE. Amy, do you remember what does PACE stand for? I don't remember now. I have to look it up. But anyway, so it's a community engagement volunteer project every student has to do. So I think you have to do at least 10 hours of activity. So there are a variety of projects. Some of our students are involved with disabled athletes who, like, for example, like help them with skiing trips or playing basketball. They're like a group and team at Shirley Ryan Ability Lab. They have like a weekly basketball tournament or games. We also have students who end up being involved in let's say, retirement home. I have one advisee, and it's sort of like you shape how you want to engage the community. Like, so I can give you a couple really kind of out of the box examples. So I have one advisee. He is really into meditation. So he wants to make his project about meditation. So he found a retirement community and convinced the administrator that he can be there to teach meditation to the residents. And it was very, very well received. He was actually invited back after his PACE project to continue engaging these residents. I also have one advisee. She was a classical ballet dancer before coming to PT school. So she wanted to be involved in the ballet community. So she found a studio that trains teenage girls in ballet. And because now she has PT knowledge, she kind of reflected back on the day she trained. There were a lot of inaccurate or incorrect techniques or skills they did. So she designed a curriculum for these girls based on her PT knowledge and PT skill, and deliver that curriculum. So there are many, many ways. Yeah, I can go on now. I have a lot of advisees. They just have like wild ideas what they want to do. When we welcome those, we support those.
Yes,
so those are the opportunities.
Title of the course itself, PACE, stands for Professional Advancement and Community Engagement.
There we go.
And that it's actually a requirement for
Yes.
the DPT program.
Thank you so much. I really appreciate it. That information is very helpful.
Awesome. Thank you, Cheryl, for the question. And so we have Valentina next, so you can go ahead with yours.
Hi, thank you. I was actually wondering, what is the most difficult portion of clinicals that you find graduate students have, or in your personal experience, what was the hardest part about doing clinicals that graduate students didn't expect going into it, that they realized doing clinicals or being in different communities or different PT backgrounds?
I'll go, Amy. Trying to think. So you're saying like when people are doing their clinical and outside of the school setting, and what are the challenges they face? Is that what you're?
Yeah, so is there something with interacting with different patients, or, you know, portions of writing notes or insurance that they face that they didn't quite take into account before going to clinicals that they found quite challenging?
I think neither Amy and I are the good, like, right person to answer this question. Maybe Amy knows, but I'm just trying to think, because usually our CEs, clinical education directors, would know more. I'm just thinking about experience I heard from students. Probably depends on your setting. Like I had one student who went to Indian reservation. So that was a very different experience. She told me she had patient walking an hour to get to her clinic. And she could only see that patient maybe every 2 weeks, just because the transportation is such an issue, right? And they have a lot of comorbidities and inequity. So it was an eye-opener for her. So she said at the beginning it was difficult for her to figure out how to communicate and try to pack everything in for the next 2 weeks so the patient can go home, have something to work on. So I think depends on the community you go into.
I think they do talk a lot about like the complexity of patients. And so oftentimes it's not just a simple orthopedic or a simple one primary system problem. So that actually is a strength from a standpoint that if you want to go into orthopedics, how much do you know about treating upper extremity lymphedema problems with patients who have cancer? And so we have a half, summer course on lymphedema management and dealing with cancer patients. So I think that's probably one of the biggest challenges, like seeing the complexity, not only from a psychosocial perspective, so like factors that you are mentioning, insurance restrictions, home environment, support systems, anything that, from a multi-system involvement. I think these are all things that make going on clinicals just so much more of a challenge than what you experience in school.
Yeah, so like we have the psychosocial aspect of PT. That course would address a lot of those. And the other thing is we have 3 full-time directors of clinical education. So they often are in close communication with the students or their clinical instructors. So if any of those issues arise, they will be there and provide resources and support.
Great, thank you so much.
Awesome. Thank you, Valentina, for your question. So we've got 2 more questions. We're going to wrap up with these last 2 questions from Haley and Clarence. And then again, I'm going to be sending you all a follow-up email that will have both Dr. Seitz and Dr. Chang's email addresses so that you can ask them any more questions that you might not have had the chance to this evening. So we'll go with Haley and then we'll finish out with Clarence.
So before Haley goes, I do want to mention that Daniel's being very respectful and saying Dr. Seitz and Dr. Chang, but we usually go by our first names, and we do that with the students because you're going to be colleagues sooner than later. And we feel like if I can respect you, you can respect me, and we like to have that personal kind of relationship with the students. So no offense, Daniel, but I do think if I got an email as a follow-up Dr. Seitz, that's nice, but feel free to call me Amy.
You know, I actually have a personal reason. I have had a lot of professors in my life, female professors, who like haven't gotten, who have been like the only females in their field and who haven't gotten the respect that they deserve. And so like, I'm just always conscious about that. So
That's
I'd
very
say
good.
that's like,
I appreciate that actually. So,
yeah.
but you guys feel free to call us by our first names. Okay.
Yeah. Thank you. So we'll go ahead with Haley.
Okay. Hi, I'm Haley. I just graduated from the University of Michigan as well. So my question is, what is your take on developing relationships with students? Do you feel it's more of an effort on the students' hand to develop relationships with the professors, or do you feel as though it's like 50-50?
See, developing. So we see students a lot, and because of all the lab sessions, we're very close with, when we see students and we're always working with them. It's not just because you can imagine undergrad, you have a class full of 200 students, right? And you have the professor, instructor up front at the podium talking. Then afterwards, they just leave. Then there's no contact until the next class. But because our setup, we see students all the time, and we don't really have office hours. Students are encouraged to just seek us out by making an email appointment. And so we're quite accessible to students. And like I said, I see students in lab a lot. So often like a lot of relationship develop that way. What else? Is it 50-50? Yeah, go ahead, Amy.
I think, you know, initially when you start the program, you're assigned an advisor.
Oh yeah.
And so we have, you know, regular opportunities where we have to meet with you for these PACE projects. So that it forces you to reach out to your advisor and meet on a regular basis. So that number one, you can talk about things that may be bothering you, not only with school or what's going on in your life, but also it gives you a chance to get to know a faculty member fairly well. So usually you would know your advisor well. I think the other group that you tend to see a lot more than you do just the other students in the class is your synthesis group, where Allison talked about the projects that you do for a 2-year period. They tend to be students who chose the project based off interests that they have either with that particular project or that particular practice area. So I think, you know, those students we see every semester and we meet with them separately as a small group on a weekly basis throughout the program. So I feel like those are really ones where a personal mentorship relationship or a more close contact are naturally facilitated. Certainly I have other students who reach out to me and say, I'm very interested in X, Y, and Z. And just like Allison said, you know, I want to learn about running or so forth. So that probably takes a little bit more initiative on the student's end if you're not in a synthesis project or you don't have an advisee. But I think faculty are very interested in that, because if you have something that they're passionate about and you relate in that way, usually we have, you know, very receptive to that. That's something that we enjoy.
Yeah, and the other thing is that we, a lot of classes, in the didactic part, it might be like the whole class, but often in lab, it's in small group. So it's very likely in most of you, in anatomy lab, it's 5 students with the tank and faculty, right? In kinesiology, we have a lot of small group activities, our lab. So often it's like 10 to 12 or students with 1 faculty. And in ICDM, which is Introduction to Clinical Decision Making, again, most of the class time are actually group-based. So you end up being a lot of groups, and then you develop more intimate relationship with the faculty leading that group.
Okay, great. Thank you so much.
Awesome. Thank you, Haley, for that question. So we'll finish off with Clarence. Take us away.
Yeah, so before I start, I just wanted to mention that I'm also a career changer. So it's nice for me to hear Mary Kate and John mention that they're starting this journey too. So I hope it goes smoothly for all 3 of us. So my question, I've kind of gotten different feedback based on who I asked the question to. And so I was hoping to ask you two because you're experts in orthopedics. But so I've had some PTs tell me that if you want to go into orthopedics, it's helpful to do an orthopedics residency. I've had others tell me that residency means that you're just like not paying off your debts, so you really shouldn't do it. And then I've had some people say like, oh, you should try to get a CSCS through NSCA and like build up some credibility by doing something like that. And so I'm kind of, I mean, I'm not set on orthopedics, but it's definitely a strong interest of mine. And so I guess I'm just curious about how to balance all these different certifications and skill sets that I may or may not want to acquire. And I was just curious what you two had to say about that.
Amy, you want to go?
Sure. So first I say we get this question from a ton of students in the program. So we're responding to this in a number of ways. I think I usually ask, you know, what are your interests? What do you want to do when you grow up? Meaning graduate and kind of go down a career path. You know, residency certainly gives you a step up a little bit quicker in your first couple years because you have dedicated mentorship. And not that you can't find dedicated mentorship as a new graduate in your work environment, it just becomes more difficult and it takes more effort on your end. This is forced time that has to happen and it can't get canceled. Now, that comes with a cost. So you're usually paid less. In some programs, you also have to pay a tuition. So I think not everyone is in a position after they graduate where that's an option for them. And so for me personally, you know, residencies were not as popular when I graduated. And I looked at them and decided I didn't want to move to California from Ohio. And I didn't do that, but I chose, you know, it was a great time to get a job. I had 6 interviews, which was very fortunate, and I got to choose the best opportunity. I just happened to choose the one that was furthest away from my house, the least paying, but it was because they had an outline plan for mentorship. So I think, you know, as you go on clinicals, you will learn more about those environments and understand what you may want to do. But certainly, you know, there's life circumstances, particularly, you know, if you're have a significant other and where you want to live. Like there's just so many factors that you don't necessarily need a residency to be an expert. It just facilitates that path in your first year much easier. So that would be my 2 cents on that.
Yeah, I agree with Amy. I think when you're a new grad, having good mentors are really important. But it doesn't have to come through residency. But like Amy said, residency just gives you a structured learning environment versus you trying to seek out experts and learn through your mentors in your clinic. And depends on where you work. Maybe there's nobody who can really mentor you. Then that could, like your first or 2 years, you will be on your own trying to improve your clinical reasoning, clinical skills. So ideally, if you can find a setting, like Amy talked about the shoulder service and Mass General, that's an excellent place to work because she probably got a lot of mentoring at the beginning. So there are places you can find that has good mentoring plan you can do without going through a residency, and you can still get specialty certification without residency. So, but again, it's personal choice, right?
Thank you so much. That's nice to hear.
Oh, awesome. We have had some fabulous, wonderful questions tonight. And, we are all going to be in touch. I was just looking back up at the sign-up sheet, and it looks like all of you are going to be applying to DPT programs this summer. And so, PTCAS is opening up within the next month. And so I didn't mean to freak any of you out. I just saw some cringes and some winces, but this is an exciting time. And we, just hope at Northwestern that we're giving you plenty of information and plenty of engagement time so that you can make an informed decision on which program could be the best fit for you. And so that is why even the follow-up email I'm going to send you will have Allison and Amy's email address included there in case you want to ask them questions. Again, I'm still available if you want to ask more questions about the application process as you gear up for that time. So thank you all. You got something?
Yeah, can
Allison?
I say one more thing? I'm sorry. I'm looking at the clock. It's like way past 1 hour. I'm sorry. But I just want to say one more thing that came to my mind is we have a very, very wide network of alumni, and that have come in handy in so many times. I have students asking me, one student said, I want to talk to someone who does canine physical therapy because she likes dogs. I'm like, I don't know anyone. And I went on LinkedIn and typing Northwestern physical therapy, and I actually found one or two. So the network is very, very helpful. And when you go to a clinic, you notice that we have a lot of grads around Chicagoland, and they could be potential future job, your boss who might hire you. So the network is a big plus to me.
Yeah, I think my parting thoughts are, number one, this is really about finding a match for you. And so we are very biased. You're going to hear all our biases and everything we present, but certainly you need to find what program feels good to you and you can relate to the people who are there, because that's going to be a big chunk of your time and a big commitment. So we really only do this, and we talk positively because we certainly believe this, but I want you to, be open and honest with yourselves when you're making decisions. And it comes down to what's the best fit for you. Mm-hmm. And we want to match. We don't want to force this on someone. And we certainly don't want to try to sell something that we don't have.
Is a perfect ending. Thank you, Amy and Allison, for joining us tonight and for your time. And thank you all for engaging with us as well. And I will be sending you a follow-up email, and we will be in touch, okay? Other than that, I wish you all the best evening, and take care. Good night.
Good night.
Thank you so much. Good night.
Thank you.
Thank you.
Bye, guys.
You're welcome.